Okay, so, as I was walking up here, thinking I put a coding talk right before a break. That was maybe not the best idea. But and usually I have like Pete Manis or Seth Brown, one of these people on 3P who know everything about coding, do this panel because coding's important. We don't get paid unless we code it right. And if we code it wrong, then it costs us more money because it takes our staff extra time to do the appeals. And God forbid we have to do the peer-to-peers, which is happening too frequently. So I thought, well, let's just wing it from a rhinologist standpoint. When I was at the university, I did a bunch of 31299s, right? These unlisted endoscopic procedures. Sure, 31299, do it, compared to this. Allegedly, they would say I would get reimbursed for the RVUs. I have found out that's likely not the case, and certainly in private practice, if you do an unlisted code, you're going to be donating your time, and I don't think anyone feels that that's right. So this is some questions about coding. I might even put you on the spot, since that's how I tend to moderate. But actually, I'm usually a nice moderator. So who are the experts? And that's a good question. Who is it? Because there are some third-party groups out there, companies that make their living who are not otolaryngologists, and they say they are the experts, and they think they can tell us what the proper coding is. And over the last 18 years of doing this, I have had some of my most frustrating, loud, aggressive, professional arguments with some of these companies. And the answer is, we are. Us, those of us in this room, the American Rhinologic Society, the Academy of Otolaryngology. We are the experts, and insurance companies ought to be asking us, not the third parties, because the third parties are going to try to keep everybody happy, especially the people paying the bills. So there is a nice option for ARS members. You can go to the website. I don't even know if you have to be a member to access this part, but you can submit a coding or billing question. And one of the nice members of the Patient Advocacy Committee will take a look at it and write you back. And this can be if you're having problems with a payer that's denying CAT scans, or something like Aetna, who is requiring a post-treatment CT scan within 1 month. Otherwise, they won't authorize sinus surgery. You can complain to them, and they'll kick it up to the next level. There's been several situations in the past couple months where this has been utilized. The Academy also has a service at entnet.org, and it's too bad Doug's not here because clicking on this link will lead you to a dead website. So we need to talk to Doug about getting this back on. But it is, maybe I just clicked wrong or something, but there is supposedly a resource through the Academy that can do that. So it was kind of nice because, Raj, this is going to piggyback off of a lot of your talks. You did some very nice discussions about these bigger surgeries, and we're going to talk about how to actually get paid for them. Because it takes extra time and the right and wrong ways. So there are a lot of ways to skin the cat when we talk about inferior turbinate reductions. We have excision, we have submucosal resection, superficial energy like RF energy, submucosal RF energy or bipolar energy, and then there's outfracture. So I just wanted, not that this is going to be a turbinate talk, but I want to hear from each of you. What's your go-to system for doing a turbinate, and what do you code? So we're going to start with Craig.
I think maybe I haven't yet had the joy, but I haven't had any major downsides of using a turbinate blade. So I exclusively do submucous resection with a 2.9 millimeter inferior turbinate blade. The only exception for that is when I'm doing a procedure that I have the Aquamantis for, which is kind of an irrigating bipolar device, also from Medtronic. That does a really nice superficial ablation and actually has pretty similar, I think, long-term kind of appearance to the inferior turbinate. So I do predominantly 30140, but then occasionally the 30930 or 30801.
I was going to ask you to say that without cheating and looking at
the
slide. So
it's all just it's all a favorite.
I want to be respectful of my faculty.
I appreciate
that. All the way here. All right, Stacey, what do you do in Boston?
So I'm going to give you the caveat that I am terrible, I think you already know this, at like coding and billing, and partly because I'm an institution where I have very little control over that, and it's constant discussion. So it'll be interesting, I think, just for the different perspectives, since I don't get to choose sometimes what the institution decides to bill. So specifically for turbinate reduction, I also use the microdebrider. I actually use the 2 millimeter blade most of the time. And then if there is, as you mentioned before, Greg, some of that really thick bone, then I actually just will resect that, especially at the front submucosally. So I also use the actual submucosal resection code.
Okay, Roger, NIthin, do either of you do something other than 30140 submucosal resection?
I mean,
Because if that's all you do, then we'll.
I mean, the only thing I'll add, so typically, and this came up earlier, for FES cases, I typically don't do a big resection, but I will always outfracture those. And if they have that posterior, kind of that mulberry look in the posterior, the tail of the inferior turbinate, I'll just take a suction cautery and just reduce that. But I typically don't bill for that.
Sure.
That takes 2 seconds. But yeah, otherwise submucosal resection.
Okay, Raj?
Same. I do submucosal resection and outfracture, but I just build the submucosal resection.
So what about, what if you don't take bone? So there's a lot of devices that do, superficial makes sense, but the submucosal energy, like coblation or submucosal bipolar, how do you code that? Are you using these new codes? Anybody using they're not new. Well, 30801 and 30802 are a bit new, but does anybody recognize those codes? All of a sudden thinking if you're not taking bone, yeah, you probably should be using these codes because it does require taking bone to justify 30140. So just a heads up on that. All right, now this comes up because different payers will allow different numbers of postoperative debridement. So the question to you guys is, what is a postoperative debridement? And I'll show you this one. And this is I'd say a little bit more obvious. A lot of infectious crusting debris. You're going to spend a fair amount of time numbing up the patient, cleaning your little instruments, and eventually getting all of this out. So any disagreement that that's a 31237 sinus debridement? Okay. And what about this one in the middle? Less debris. You're just doing an endoscopy right here, but all of a sudden a suction comes in. Does that change the code?
Can I say something just because we had an issue in Massachusetts recently. I'll be curious to see if anyone else has either related to documentation. So there were a lot of denials that were happening for 31237 debridement post-op for sinus surgery. And finally, after much discussion and back and forth and asking questions, it is essentially that the insurance company, you have to document the fact that you used something like an actual instrument. So just saying that you did a suction alone, in the note even, that was actually denied. So that was Blue Cross Blue Shield in Massachusetts area. So even this is a different issue, what you're talking about, what you're actually doing. But from a documentation standpoint, I think that might be, everything always starts in Massachusetts where there's some kind of restriction on something. So just so everyone has heard that. Have you seen that as well, Greg?
No, but I would say I'm pretty conservative about my use of 31237. I don't want to bias the panel. So what do you think? I want an answer. What do you think about this? That suctioned out some stuff, pulled out a crust, resuctioned out a little bit. Is that a 31237?
Maybe on a slow day it is, Doug. I don't know. Greg, I think the key is it's your own conscience, right? There's plenty of scenarios where you'll put so much work effort and you won't get that, like the Lothrops we were alluding to. That's a 22 modifier of a frontal sinusotomy bilateral, and that's it. So I think you kind of come to a comfort level that's rational, document, evidence provided, and just kind of ethical that you think is reasonable. So I wouldn't bill a 31237 on that, just the endoscopy, because there's a time component and all this stuff that we know. Just one other comment to piggyback on what Stacey said. I think, part of it is making sure your documentation is accurate, and not just that you use a forceps or a Blakesley, but that you anesthetize the patient and you took time to wait for the anesthesia, all of that stuff. So it actually looks like a procedure note because you're billing a procedure code. So the more you can sort of flush that out with smart phrases, I think the less friction you're going to have on the payment side.
It's truly interesting when you can spend almost a half hour on both sides doing an in-office polypectomy. You've done a previous beautiful skeletonized sinus surgery, full house vest, polyps come back, and you're like, oh, I can take care of this in the office. And by the time you really numb them up and go through the process, that's a 31237-50, and so is this. So that's my point, because there is a lot of pressure from the payers about 31237. And this one was even lesser. So I was trying to bait you guys into saying the middle one was a 31237, and this one's really not. But what else is there to consider? And in my opinion, if you're going to charge a 31237, that patient's going to get the bill. It's not a small bill. And if you spend just a couple minutes in there or a minute, and the patient gets a bill for $2,500 or $2,000, you really have to justify it not only to your own conscience, but to that patient. And it's certainly not worth a patient complaint about that. And then there's the issue of multiple debridements. Many payers will put a limit of 2 debridements per case. Now, my experience with Lothrops is you do have to do a little bit more debridement than that, and I counsel the patients ahead of time about that. So I just am pleased to hear that we're coding similarly, and I hope you do too. Anybody on the panel do Vivere? Craig, how do you code it?
I was coding it.
Nice job looking at the screen.
Let me help you out. I was coding it initially as a 30117 when I first started, but then they came out with the radio frequency code, which I believe I get them confused between the Vivere or the Vivere and the Latera, but I think it's a 30469 for that code, and so that's what I use now.
Do you code anything for the turbinates, assuming you do RF to superficial to the turbinates?
So I often, when I do that in clinic, I'm often kind of trying to take a more holistic approach. So I actually will do a submucous resection in clinic with a 30140 and then do the 30469.
So you're going to use a blade and the Vivere wand.
That's what I typically will
use. Okay, all right. Well, if you just use the RF, this is the answer to the quiz. It's 30801. The nasal valve, 30469. There you go. And then what about the septal swell body? This is a real thing. Not in everybody. A lot of people have a septal swell body. Do you code for that?
Well, sometimes you have to use that code to actually get this approved for certain insurances. So I often will kind of prior auth that code, the 30117. And so I will, I actually have that. Yeah, I'll use that as well.
Right. So everybody remember in residency learning that it's just as evil to undercode as it is to overcode. Is that the silliest thing you've ever heard? Right. But this is an acceptable way of coding for this procedure. I'm with you. As long as a payer pays for one of the nasal valve or the septal swell bodies, then that's good enough for me. So something to keep in mind. PNN ablation. Do any of the 4 use cryo or RF energy?
I use RF.
Okay. Do you remember the code?
31242.
What about this one?
That one you can, well, that's what I, before 2024, that's what I was going with.
Okay. 31242. Good job, Craig. Cryotherapy. Anyone in the audience know the code for cryotherapy? It's close to this one. It's not even a trick question. 31243. It's one number above. So these are the 2 codes that were approved just as of January 1st. Prior to this, we were using 30117, which is an appropriate length of time code to use. But now that we have these codes as of January 1st, 2024, can we use it? What if insurance says no, 31242 or 31243 is experimental, which is what they do with insurance companies? What do you think, Greg? Can we use 30117?
I think you can still use 30117. I'll still try to get 30117 if they deny the 31242 under the same reasoning that we were using it before. I don't know if it's legal or not.
I would argue no. All right, so that's the dilemma. This is the frustration when it's so exciting. All the companies are like, hey, we have a new CPT code. You're like, great. Medicare is going to cover it. Awesome. But no commercial insurance is going to cover it for probably a year to a year and a half, maybe 2 years. It will always be investigational. So there's this significant, like, oh boy, now we have a new code. And it's really, it's going to be a challenge, an ethical challenge to use 30117 when there is an existing code presently. It's hard to justify it to the payer. And again, we have to kind of police ourselves so somebody else doesn't police us. Raj, how do you code a Lothup or draft 3? Anybody in the audience do a draft 3, by the way? other than faculty. Okay. You might want to do it or consider and this is sorry for the divergent, at least get comfortable with the draft 2B, drilling out the floor of the frontal sinus. There's many, many times where I consent a patient for frontal, thinking in my head draft 2B, or might have to do a draft 3. If there's a frontal septal cell or some really tough anatomy up there, but just drilling off that frontal beak on one side, it actually works. And so it's something to consider. Anyway, how do you code it?
Right, so as I mentioned, bilateral frontal sinusotomy, 31276, I think that is, with a complexity modifier. And then just when you put the complexity, so we're actually, at the clinic, we don't actually put the CPT codes. We're mirroring it, long story short, we just put the words in, not the actual numerical CPT code. But you want to say why it's complex. So took longer, drilling near the eye, whatever other scenario you want to put, revision surgery, scarring, and so on. I like the idea of the 2B because as long as you remember, when you go into the frontal sinus, that ostium is in the posteromedial aspect of the frontal sinus floor. With impunity, you can come from that ostium hole that you made forward with a drill, with a Hosimon, whatever instrument you like, to get a big as opening as you can to get the drug in. So that's how I'd bill for it.
Right, and I agree. And then usually there's an ethmoid component to it as well, and the modifier 22 is for the complexity. What about 30117 in this situation? What about destruction of nasal lesion, the osteotic bone? It's been proposed. Is it wrong to do that? You are destroying a lesion if there's osteotic, hyperostotic bone.
Yeah, I don't look good in orange.
No way.
I don't look good in orange, Greg, so I would say no on that one.
So, NIthin, why would that be incorrect in your opinion?
I think there's the frontal sinus with additional modifier code is actually describing exactly what you're doing. So that's why the other one would be incorrect.
So the frontal sinus code talks about drilling out the top of the septum and the inner sinus septum?
That's a 22 modifier. That's a 22
understanding
modifier, the additional work needed. So that is describing really what you're doing. And then you're describing it, but I don't think you're describing ablation of a lesion. You're ablation of normal tissue.
Yeah, or slightly abnormal if it's osteotic, right? But okay, good. All right, Stacey, how do you? Well, do you code at all?
No, so I mean, we do the same essentially as what
You just
Rod was
write,
saying.
and then
we
they
have
do
to,
it for you.
Dictate everything, and then essentially and I think when you are in that situation, part of what we end up having to do is then you have to on the back end make sure, obviously, that it is being coded properly. So that does require checking frequently. And so same thing for this, I think similar to what we just talked about with the draft 3.
All right. So are you in agreement? 31267 plus part turbinate resection code. Raj, would that be correct?
Yeah.
Okay, with modifier 22. Good. And that actually pays pretty well, right? It doesn't take a whole lot of time and it makes sense. All right. Aside from these things, which we'll talk about, how to avoid the dreaded peer-to-peer. Anybody have to do peer-to-peers? Let's just say this last month. Raise your hand if you've done one in the last month. Yeah. Okay. I love the little cricket that comes out. All right. So this is my take. Knowing the policy. Painful, painful, painful. Every payer has a different policy. There's some common threads, 2 weeks of antibiotics, nasal steroid sprays, sinus irrigations, and documentation, right? That's the key is you have to send it, you have to put that in your note. Short of that, talking about the CT scan, putting in a CT scoring system, or I like to cut and paste a couple key images. There's been several times where I've done a peer-to-peer, and it's usually not with an otolaryngologist, and they'll say, the radiology report said only trace or minimal mucosal thickening. Or they will say frontal sinuses are clear, yet the frontal recess is completely blocked. And I'll say, can you look at the picture on my note? And 50% of the time, what do they say? Oh, I don't have your note. Right, that's common. But when they do have it, they look at it and they say, oh yeah, I see what you're talking about. Okay, surgery approved. So what do you do? What's anything at Penn, or do they do everything for you? They take care of you and they cuddle you and it's all good?
The pictures in the notes have actually been really useful. So we've shifted that way as well. Again, whether they have it or not is up for debate, but that's been the most helpful. But yeah, we have the same problem. They'll say, well, maxilla is approved, sphenoid is approved, but the ethmoid looks not too. I'm like, How am I going through to get to the sphenoid? You know what I mean? So that's actually been more of the challenge is they'll isolate one code on each side that they'll say is not approved.
Right. Right. And it's, for those of you who don't use SNP, at least on a PC, the SNP, you just type or search in the bar for SNP. All your computers have it. And it just pops up, you do a quick SNP, and then you paste it right into your EMR. It's that easy. It's really, really easy. Craig, you're in private practice now. It's a challenge when you get a peer-to-peer. Any suggestions you would have?
Yeah, I think the best. I think the interesting about peer-to-peer, as onerous as they are, I think the person on the other line is actually trying to help the patient. I find that documentation is really important. Being able to justify why you're doing something is really important, and I think being really kind and understanding of them has, I think, been really helpful. You kind of thank them for their time, kind of try to walk them through it. Most of them now, I believe the new law is they all are otolaryngologists. So I think that changed recently, and so I think a lot of them have that basic knowledge, and as long as you can kind of come to terms with them, I've had a lot of success. The thing that is frustrating, I agree, when they approve through in 276 and through in 267, but they'll approve through into like the through in 281, but they won't approve the through in 259, the sphenoid ethmoid code, and you're like, well, what am I supposed to do with the ethmoid? And then they have no answer for you, so you just have to do what's right for the patient, which I think is frustrating and challenging.
Yeah, I'm not sure about the new law. Just January, I had a peer-to-peer. It was with a family med doc, and I didn't like their answer. So I requested a ENT second peer-to-peer, which again is more uncompensated time from us, which totally is not fair. We got an otolaryngologist. She says she was still practicing, and I had to do frontal sinus surgery on a patient. And so I had coded just unilateral maxillary partial ethmoid frontal. And she says, well, yeah, I see the frontal, I see a little bit ethmoid disease, the maxillary is clear, so we're not going to approve the maxillary code. I'm like, well, so you want me to get into the frontal and the ethmoid and not open up the maxillary? She's like, oh yeah, that's how I do it all the time. I said, well, you should come to my sinus course someday and teach you otherwise. Yes, Doc.
Could you just have gone forward with it, whatever she approved, instead of doing all these peer-to-peers, and then you do the maxillary sinus and you say it's clinically necessary to do the maxillary sinus, put your argument in there. They often pay on the back end. It's less time for you because your time is more valuable. The billing people can collect that. Just like your one about they authorized all these sinuses but not the ethmoid. Just go and do it. Do the ethmoid, and that's where you put your two sentences in. You say it was clinically necessary to do it for presumably good reasons. You're going to find that it'll be less administrative time for you than doing peer-to-peers. That's my thoughts.
Yeah, it's a really interesting thought. I appreciate the comment. And certainly I went ahead and did the maxillary, and I mean, it doesn't take long, but I don't know if we pushed it on the backside. So thank you for that suggestion. Yes?
So we just have a checkoff list where, was the patient on saline irrigations? Were they on steroids? Were they everything, so that my staff can check everything off before I even see them, and I know, have they seen an allergist? All the different things that they're going to ask you on those peer-to-peers. And if we've done everything, then usually it sails right through.
I agree. I think check boxes, checklists are fantastic, especially when there's some complexities like balloon dilation of the station tube. As long as the boxes aren't checked before you see the patient, speaking from an expert witness standpoint. Okay, and I'm not giving that lecture this year, but that has gotten several people in trouble if they check all these boxes before the patient walks in the door. Yeah, good thought. Yes?
What do you consider a 31256? Like the limits of taking off the whole unsonate, is that still 31256? Or when do you consider removal of tissue?
So the difference will be between, the maxillary codes, 31256, which is just a maxillary antrostomy, versus 31267, maxillary antrostomy with tissue removal. Take it to my esteemed colleagues.
Inside the sinus is when if we're talking with tissue removal, it's specifically if you're doing tissue removal inside of the sinus. At least at my institution, is how we interpret that.
Okay. And what if you're reaching around with a giraffe and you pluck out a little mucus retention cyst? Does that count? Is that 31267?
Yeah, counts.
Okay.
Took something out.
Howler cell versus what if you spend 20 minutes flushing and debriding out a giant mycetoma? 22 modifier. There you go. Yes.
So I have a question on what is the best way to proceed when you get a denial that you feel like is really not consistent with standard patient care, like for a CT scan. And there's one in particular that I have submitted multiple times, and this patient has clear infection on endoscopy. They've been on multiple antibiotics, oral steroids, all of the topicals. And all I have is a letter from the insurance. I think I actually texted you about this. It says a CT scan of the sinuses is indicated for eye swelling or severe infection, severe headache, or brain changes. And that's the indication for a CT of the sinuses. And there's no option for a peer-to-peer. All I have is, oh, you can submit this letter. And so I'm just trying to figure out how to proceed for that type of thing, because I feel like that's clearly inappropriate denial.
Right. So sometimes it's important to look at the actual letter that they send you, because usually it will spell out why it was denied, and then you just have to justify your argument. That situation you're talking about is quite a bit different. There are times where you can change the indication for the code. So the CT max face for preoperative planning is a different code that you can submit compared to just CT max face. Any other thoughts with that?
I think with the preoperative planning, my experience with a couple of these was that they said that they wouldn't cover, the patient would have to cover out of pocket if it wasn't for a diagnostic purpose. So
Yeah.
I guess I'm wondering, is it best to submit?
For just an acute infection or for like singular versus recurrent acute?
The patient that I'm trying to get approved, no, this is chronic. This is like a patient who's been on 6+ courses of antibiotics, has purulence on endoscopy, has positive cultures, and I have a letter that says, basically, unless there's abnormal brain changes or eye swelling or severe headache, it's not approved. So I'm wondering, is that something to submit to, to ARS or some the state commissioner or what?
Well, I think we even talked about submitting that one to the ARS, and it's just a frustration. There are times where we're just going to have to fight back. You might lose the battle now and then, but other than asking for a peer-to-peer or demanding a peer-to-peer, you might be stuck with that.
Is that for just CT max face or for just a screening CT? Yeah, because I had a similar thing where they didn't want to do a CT max face like a priori for a patient. So I said, well, then are we going to get a CT sinus? Then if we need to do surgery, we'll do another CT, and that's what they wanted to do. So that's what we did. Great use of the system.
Yeah. Last question, anybody, before we break?
Can I make a comment? The thing that you guys are saying about the lists and trying to meet the criteria and so on and so forth, the key is for the provider to have that information at the right time. Because all these scenarios are you guys are on the back end trying to fix it, and and truthfully, there's like 200 or 300 insurance companies your clinic will interact with, and they all have slightly different things. And if you have this mindset that like I'll make the most stringent thing, and if we do this for this, and it'll cover everyone, you shouldn't do that because you'll be over treating so many people. So if anyone's curious, we have a system where it's software driven, but we have our authorization department continuously updates it. So if United Healthcare says you have to say these 3 sentences, they'll put that there. So real time, when Eric and I are seeing a patient who might be a candidate, we can see that you have to say that, and that we do that, and then they sail through more smoothly. But it's an information war, and having the information at the right time that's continuously updated, that's the dilemma. That's my comment.
Well, in 5 years, the AI will do it for us. I'm looking forward to that. So, all right, let's take a short break. We'll re-adjourn at 3 o'clock. There's some light snacks and then drinks, as you know, in the little lunchroom behind me here. Thanks, everybody.